Hi everyone, thanks so much for jumping on for this evening's live. In recent live streams, we've covered AMH, AFC, as well as diving into Dr. Rusty's research on AMH and AFC variability. Today we wanted to use this live stream to answer some questions from some recent users in the comment section, and also feel free to comment a question below, and if we have time we can answer those ones as well. Awesome. So I'll just get started, Dr. Rusty. The first question that we have from a recent TikTok video is a user has asked if they have a submucosal fibroid that is greater than 4.6 centimeters, would you recommend that they remove that before trying to conceive?
Yes, so in patients with infertility, how you manage submucosal fibroid depends on two things. First is the size of the submucosal fibroid, and second is a type of the submucosal fibroid. So in terms of types, submucosal fibroids can be in 4 different types: type 0, type 1, type 2, type 3. Type 0 submucosal fibroid means that fibroid is protruding inside the uterine cavity. Most of it is protruding into the cavity, and it is called pedunculated fibroid. So almost all of it is in the uterus, and just it is just hanging with the root of the fibroid. That's called type 0. Second type of submucosal fibroid is a type 1, where you have got more than 50% of fibroid is protruding into the uterine cavity. Less than 50% is sitting inside the wall. Okay, so let us imagine the uterus, right? Yes, uterus has got muscle layer. Inside the uterus you have endometrial plate, which is a basal layer of the endometrium, which regenerates and creates new layer every month. After menstrual period, you have women lose menstrual in that endometrial functional endometrium. So in type 1 submucosal fibroid, so more than 50% of the fibroid goes through this endometrial plate and protruding into the cavity. In type 2 submucosal fibroid, more than 50% of the fibroid still sitting inside the wall of the uterus, which is in the myometrium, muscle layer of the uterus. Less than 50% is protruding into the cavity. In type 3 fibroids, where all of this fibroid is in the muscle layer of the uterus, but it's just touching the endometrial plate. So yes, in type 0 fibroids, you should really remove that fibroid. So best way of removing the fibroid is a hysteroscopic resection. So, but it may not be easy to resect such a big fibroid as a 4.6 centimeter fibroid. So with a hysteroscopy, it may require multiple procedures to remove. And sometimes you may, if it's very big, you may need to do open or laparoscopic myomectomy. But it can be removed hysteroscopically. In type 1 submucosal fibroid, most of this fibroid is protruding into the cavity. If it's smaller fibroid, yes, you can remove with a hysteroscopy. But if it's big fibroid, like 4.6 centimeters, you should not. Why? Because when you try to remove that fibroid, you inevitably create big defect in the myometrium, in the endometrial plate. So endometrial plate is like stem cell layer of the surface of inner surface of the uterus. If you have a little bit tear, a little bit defect, next month it grows and it covers. If you have a huge defect, if you have 4.6 centimeter fibroid, and if you start digging into the cavity, if you have a huge defect, especially if you cannot remove the fibroid completely, then you may have a gapping hole, and which heals with a connective tissue regeneration, and that causes Asherman syndrome. That causes adhesion of the uterus. So actually, uterine adhesion can be more problematic than fibroid itself. So this is why in such a big fibroid, you should not try to do hysteroscopic resection. So even if it's type 1, in this type of fibroid, you need to remove this fibroid from outside. Outside means myomectomy. Myomectomy means that you can do with a keyhole surgery, laparoscopy, make incision on the surface, outer surface of the uterus, and then shell out that fibroid, or you can do open surgery, open myomectomy, make incision on the surface of the uterus, then remove that fibroid. And when you remove, you need to ensure you don't have a defect on the endometrium, and if you breach the endometrium, then you need to ensure you need to suture, and you need to check that endometrial lining is healing by monitoring, by doing scan next month after myomectomy, and also maybe doing even hysteroscopy to make sure that Hashimoto's syndrome is not developing. In type 2 fibroids, so any type 2 fibroid you should not remove hysteroscopically, because type 2 fibroid means most of the fibroid is sitting in the wall of the uterus. Less than 50% is protruding into the cavity, which means you need to cut the endometrial plate and you need to start digging into the wall of the uterus, which is a muscle layer that can cause bleeding. It can cause scar tissue formation. So type 2 fibroids you need to remove. If you're removing surgically, you need to remove by myomectomy, making incision from outside and remove. Type 3 fibroids, which means that the large fibroid is just touching endometrial plate, so it shouldn't really affect your chance of implantation, provided it's not causing change in the contour of the endometrial cavity. So if it is not, then you should just ignore that fibroid. You should just take into account, but you shouldn't do much intervention. So, and if that fibroid is changing the whole anatomy of the uterus and the cavity is not collapsed properly, which means you have a fluid collection in the cavity, yes, you may need to deal with that fibroid by doing myomectomy surgically. And also very good treatment in patients with infertility or on undergoing fertility treatment is using GnRH analogs like Zoladex and Prostap, Lupron or Decapeptyl to shrink the fibroids. Fibroids grow on because of estrogen hormone. If you reduce the estrogen levels, the blood flow to the fibroids reduces, and receptors of the fibroid, which is estrogen receptors, will send a signal that this fibroid should start shrinking. It becomes smaller. So if you can't manage this fibroid surgically, you can use the Prostap or Zoladex for 4 months to 6 months to shrink the size of the fibroid. It doesn't get rid of fibroid, but it reduces the size, so by 25 to 50%. So let us say if it's type 2 or type 3 fibroid pushing to the lining, when it shrinks, it retracts into the wall of the uterus, then it can go away from the cavity, then that opens a window for you to do embryo transfer and achieve successful pregnancy. Yes, so in terms of how you manage submucosal fibroids, it depends on the size of the fibroid and the type of the fibroid.
Thank you, Dr. Rusty. The second comment from a user on a recent video, this video was titled, What Does My AMH Level Mean? The comment is more of a statement, and my question to you is, would you agree with this statement? AMH level cannot predict menopause at an individual level, and even at menopause, women are found to have some 1,000 eggs left.
No, it's a wrong comment, because okay, so AMH is produced from growing follicles. So when women go through the menopause, they stop producing growing follicles, which means all women after the age of a certain age, when they have a menopause, if you check their AMH, the AMH comes back as a 0, so which is undetectable. So which means yes, AMH, undetectable AMH, and not having menstrual period for more than a year is actually diagnostic of menopause. So AMH goes down predictably. So which means it's always high. In all women, it's always high when they're young. In all women, it goes down gradually as they reduce their egg reserve. In all women, it becomes very low, critically low. In all women, it becomes 0 when they have a menopause. So this line is predictable. AMH never starts as a low, then goes up for many years, then goes down, goes up it doesn't behave like this. Why? because it is direct marker of egg reserve. Egg reserve always goes down, and once egg reserve, you run out of egg reserve, then you have a menopause. So yes, in the short term, you can see the variation. Like we always say that when you do AMH test, you need to check AFC twice. So this average variation is 30%. That variation you should take into account when you're making decision. For example, variation means if you did AMH at the age of 25, your AMH is 3 picomole liters, then you checked again, it's 4 picomole liters. So there's like 30% variation. It doesn't matter. Both of them saying you have a very low egg reserve. So you need to do something about it. Not immediately tomorrow, but you need to make a plan, active plan, either to get pregnant soon or preserve your fertility. So gradually your egg reserve will go down, and compared to somebody else whose AMH is 25, once 22, second time, you have a very different fertility lifespan, and you may need to make a very different plan. So yes, when there is AMH, even with AMH, women get pregnant naturally. Most women get pregnant naturally with very low AMH, and or they get pregnant with a fertility treatment or IVF. But we are talking about the long-term prediction of egg reserve. We're not saying fertility, we're saying egg reserve. We need to distinguish between egg reserve and fertility. Fertility, we should not confuse. We're not saying AMH tells whether you're fertile or not, unless there's a undetectable AMH. Of course, it indicates that in patients with menopause, that means they cannot have a biological child. But here we're talking about egg reserve. Fertility is very complex, because even partner semen analysis is a one factor which determines fertility. Ovulation determines fertility. All other factors. There's so many factors. AMH is a test of egg reserve. So the user said that there are 1,000 eggs left when women go through the menopause. Okay, so this is observation of one study, histological observation in women who had the menopause. They could count 1,000 eggs. So these eggs, there's no benefit from this 1,000 eggs left after the menopause. Why? Because these eggs do not have a capacity to grow. So they're almost non-existent. So they do not have receptors. The reason still these eggs left after the menopause in the ovaries, because they didn't have a capacity. They could not grow. They cannot become egg to produce estrogen, or they cannot become egg to give you egg. These are primordial follicles which are incapable, with a deficiency. So if you extend this argument, this user is saying doesn't matter, even in menopause women have 1,000 eggs, so egg reserve, it doesn't matter. So no, these women will have these eggs at the age of 80 or 90. These eggs will never be activated. Doesn't mean that women retain their fertility at the age of 80 or 90. So this is a little bit misleading comment. So no, yes, after the age of menopause, some defective eggs can be left on the ovaries, and there's no use from those eggs. You can never activate, and these eggs will not be able to go through the growth and maturation. This is the reason these eggs were left in the ovaries. Now, AMH in population level, in individual level, can predict egg reserve and menopause. Of course, like we've been saying during the live streams, it doesn't predict exact year, but it predicts approximate time of menopause. In average, AMH declines from 0.5 to 1.0 picomole liters. So probably in average, it declines 0.6 picomole liters per year. So that's good enough to inform women about their egg reserve, and so that they can make plans before egg reserve runs out. But if you do AMH test, and if you, let us say at the age of 30, you did AMH test, somebody's AMH came back as 2.2 picomole liters. And saying to that patient, it doesn't matter is irresponsible, because after 4 years, they may run out of egg reserve and they miss this opportunity to complete their family. Yeah, so we cannot say when women trying to conceive actively, we should tell, yes, your AMH is low, you are releasing eggs, especially if your age is younger, you don't need to worry too much, but you need to complete your family. We are not saying with a low AMH you cannot have a child. What we are saying is with a low AMH, if you don't make a plans for future, by the time you're ready to have kids, you might have run out of egg reserve, because 5% of population have very low egg reserve, low AMH, low AFC, and they run out of egg, they have early menopause or premature ovarian insufficiency.
Thank you, Dr. Rusty. Our next question is from a user named Ruby, and this was on our screen recording of our live stream discussing the endometriosis surgery in IVF. So Ruby's question is that she is 33 years old. Her AMH is 2.2 picomole liters. Her AFC is 12 to 15, and she can't produce high-grade embryos. Would you recommend that Ruby has the endometriosis surgery?
Okay, so here we have got one specific problem. Here the AFC is high, or much higher than AMH. What's her AFC?
Her AFC is between 12 to 15.
Her age, what's her age?
33.
33, yeah. So AFC is higher, still low for her age. Okay, so in median AMH and AFC for her age should be, AMH should be approximately 20-25 and AFC should be 25-30. That's median. So her AFC is fairly low for her age, but especially her AMH is low, 2.3 picomole liters, yeah?
Yes.
So here it looks, generally, when you measure AMH in picomole liters, if you're in US and some clinics where you measure AMH in NGML, you need to multiply it by a 7.14. So to convert it to picomole liters. So if you measure AMH in picomole liters, that should be very close to AFC levels. For her, generally with this AFC, you would expect AMH should have been approximately 10-12. So if you have 10-12 antral follicles, which is producing only 2.5 or 2.3 picomole liters of AMH, that indicates each follicle producing less amount of AMH, maybe 2-3 times less amount of AMH. So why is that? Very likely she has a AMH gene deficiency or AMH receptor deficiency. Usually that comes together with deficiency of other receptors like FSH the receptors and LH receptors. Usually the patients with a receptor deficiency have problem with the maturation of the eggs. For her age, it's very unlikely she has a poor quality eggs. At the age of 30, 33, very likely her egg quality is good, but very likely the issue is related with poor maturation of eggs. So you need to improve the maturation of eggs in IVF. You do that by doing certain things. For example, you need to use broadband FSH, or you need to use FSH with additional high dose LH like Luveris, or you need to use a broadband FSH, which is Menopur, for example. So to activate multiple receptors of FSH. So this is one thing. Second thing is you need to give a high dose of FSH. So normal dose of FSH for her age, for example, should be approximately 225. But threshold for FSH may be very high, because activation of the follicles may take much higher dose of FSH. You can give maybe 450 units of FSH to activate more follicles and get those follicles into growth stage. Second is you may need to do longer stimulation. If you have a problem with FSH and LH receptors, you may need to take follicles much bigger size before you give the trigger. So then third thing is you may need to use a much more broadband trigger and much higher dose of trigger like Prignal, Choriamon, and much higher dose, 10,000 units of trigger. Why? Because choriamon, for example, very broadband trigger, and it activates multiple receptors. So it's got multiple more amino acids than recombinant trigger like Overdraw. So and also you may need to use a much higher dose of trigger like 10,000. Why? Because triggering LH threshold, receptor threshold for the trigger maybe much higher. So 7,500, 5,000, maybe too little dose. You may need to give 10,000. So you may need to consider doing dual trigger using choriamon plus decapeptyl, Overdraw plus decapeptyl. Why? Because here you use one artificial trigger, which is Overdraw or choriamon or Pregnyl, and also natural trigger, which is decapeptyl. A natural trigger may match her own receptors. So here receptor is like lock and trigger is like key. So if you use a natural trigger in addition, it may actually open the on lock, because on lock and key may match genetically. So you need to also, if doesn't work, then another type of regime you may need to use called flare regime. Why? In flare regime, you search the LH and FSH into bloodstream, and that can activate the follicles and bind to natural LH and FSH, can bind to receptors of the follicles and may activate the follicles and may improve the maturation. Here, very much we are talking about improving of maturation of the eggs, that can improve the quality of the eggs and can create multiple, hopefully, high-grade embryos. So endometriosis here is just distraction. Yeah, so endometriosis does not cause this FSH and AMH and IFC mismatch, and the endometriosis, unless it's on the ovaries with chocolate cyst, has a very little impact to egg resolve, and it doesn't really affect egg quality. So yes, endometriosis treatment may be necessary for different reasons, like if it's severe endometriosis, if there's a repeated implantation failure, if it's causing problem is access to ovaries. But here there's a sign of specific problem, mismatch of AMH and AFC in low egg resolve, and the poor embryo development. So which means here issue is a low egg resolve and very likely receptor issue, AMH gene deficiency, AMH, FSH, LH receptor deficiency, and which is very likely leading to poor maturation.
Thank you, Dr. Rusty. My final question for you this evening is from a user named Brooke. This was on our video discussing egg quantity and egg quality in IVF. So Brooke asked, do high-grade embryos give a 15 to 20% chance of successful pregnancy if you are age 41?
Yes, so essentially the chance of successful implantation or pregnancy depends on the grade of the embryo and age when those embryos were created, female age, and also condition of the uterus. These three things determine the chance of successful pregnancy. So high-grade embryo, if uterus is healthy uterus means there's no inflammation of the uterus, primarily adenomyosis, or severe endometriosis, or structural problems of the uterus like fibroids and polyps and septum, or hydrosalpinx like inflammation of the uterus and fallopian tubes. So if those factors not there, so high-grade embryo can give 15 to 20% chance in women who created those embryos at the age of 41. So in the same high-grade embryo, let us say AA grade embryo at the age of 41 can give 15 to 20% chance of successful pregnancy. So same high-grade embryo, AA grade embryo, can give you 50% chance of successful pregnancy if female age was 30 when those embryos were created. The grade is the same, but 50% here, 15-20% is here. So at the age of 35, same high-grade embryos, not same embryo, but the grade is the same, and it can give 35% chance of successful pregnancy. So this is why grade is not equal to quality. So the grade may be AA grade, 1 grade embryo. Let us say expanded placental cyst 1, which is 4AA grade embryo. At the age of 41 can give you 15%, at the age of 35 can give you 35%, at the age of 30 can give you 50%. Why? Because the quality is not the same. Because likelihood of those high-grade embryos having aneuploidy, chromosome abnormality, or poor capacity for implantation is higher as age goes up. Why? Because 80-90% of abnormalities or problems in embryos come from female side, from the eggs. That's directly associated with female age. So yes, when we give an estimate, we look at age, female age, we look at the grade of the embryo, and we also look at condition of the uterus and estimate individual person's chance when we do embryo transfer.
Thank you, Dr. Rusty. That does conclude our live for this evening. So thank you so much to everyone that joined, and for your comments. I will review those and we may be able to answer those in future live streams. As always, the recording of this live will be published to Dr. Rusty's Instagram, TikTok, and YouTube. And if you would like to tune into more live streams, we will be live tomorrow morning. Thank you, Dr. Rusty. Thanks everyone.
Thanks everyone for joining. Thank you. Thanks.